Hi everyone, and welcome to tonight's MHTV. Tonight we are talking about mental health injustice. So slightly different one for me, as I'm here with some of my colleagues tonight. I'm going to go around in a minute and introduce my colleagues to you, and we'll tell you a little bit about what we've got in store. But first I'll go over to Nikki, who will tell you how you can join in on social media. Okay, Nikki.
Hello and welcome. We're really pleased to have you with us tonight. And as ever, we really want to hear what you think. And if you've got any questions, please ask. So the way to join in, if you're watching on Facebook Live, is obviously just to write in the messages underneath and we'll see that. And if you are sort of tweeting or getting engaged in that way, if you follow the hashtag MHTV, we'll be looking out for your questions and comments. So thank you very much. Back to you, Vanessa.
Thank you. So yeah, just to say, tonight's MHTV is linked to a conference that we've got planned on February the 20th in London, which is MH Injustice. So I'm here tonight with some of my colleagues and guests who are involved in the organisation of the conference, which is basically a collaboration across several health injustice organisations. So I'm going to go over to each of my guests now, who will hopefully say a little bit about themselves and the work that they're doing in health and justice. So, Jonathan, I'm going to come over to you first because you're first on my screen.
Well, good evening, everybody, and thanks for the introduction. I'm really pleased to be here today. So my name is Jonathon Stephen. I'm the Senior Service Lead for Health and Justice, and I work in the Specialist Division within Barnet, Enfield and Harrogate Mental Health Trust. I've been in my role for about 4 years. And my background is nursing as a profession, qualified as a nurse in 1998. And I've worked across lots of different sorts of services, all mental health, covering all age ranges, adult, acute, inpatient, PICU, Camhs, IAPT. And the majority of my work's been involved with working with other partners. And I think that's the most enjoyable part of my work is actually working with systems, working with other providers, working with commissioners. And I've really enjoyed the challenges and also the rewards from those experiences. In the last 4 years, the focus has obviously moved now towards the health and justice pathways. And I've been really privileged to have the role within BEH, within the specialist division. Specialist division provides forensic services, inpatient care, as well as some really specialist outpatient provision, and also the health and justice stuff that I oversee. So I'm the operational lead, and I try and do my best to support the clinicians on the ground, optimize our partnerships, with other providers, and for us, one really important provider is PPG. They're our lead provider in our London prisons, where we are, making really good headway on transforming the design of our services based on historical learning. So it's been it's been a very busy year, the last one. We've redesigned the services and we're now in the implementation stage. It's a really exciting time, and we're really optimistic that the services that we're being supported to create and change are really well supported by both commissioning, by prisons, and all other sort of agencies within prison settings, and with our lead provider PPG. It's not without its challenges, but it's a very worthwhile endeavor. Additionally, beyond prisons, I also cover other parts of health and justice that I have operational responsibility for. They connect into prisons to some extent. Obviously, liaison and diversion services. We work in courts and police custody suites across North London. And we have some really highly specialist liaison and diversion services, again, hosted and by policing. There are a number of these. They look to support people with mental health needs, maybe coming into contact with the criminal justice system, and we look to try and divert vulnerable people so that they can get support in a more timely way, and it may be people who haven't been picked up before, and maybe people who have maybe particular stalking behaviours. We have a stalking threat assessment service, again an integrated service with the Susie Lamplugh Trust, with the Metropolitan Police, and ourselves, and then we have the Fixated Threat Assessment Centre, and again that's working with policing to try and divert people who are maybe form unhealthy attachments and beliefs towards high profile politicians or the royal family. And we're trying to counter vulnerability, essentially, and get people the help they need before maybe they inadvertently get into trouble, or they've already coming into contact and maybe heading in that direction. So yeah, absolute privilege to work in mental health in the NHS and within these partnership contexts. So I'm really looking forward to the discussion tonight.
Yeah, fascinating journey as well into where the services and where you are now as well. And that leads me nicely into Dawn, actually. Dawn, do you want to introduce yourself next and say
thanks. Thanks, Vanessa. Good evening, everyone. My name's Dawn Jessop. So I'm the Deputy Service Director for Practice Plus Group, and that's our Health and Justice Directorate. So I'll say a little bit about that and then a little bit about myself. So the health and justice side of things, we deliver healthcare into quite a few prisons across the country, and that's a variety of aspects of healthcare. So we deliver mental health, we deliver substance misuse, GP services, primary care, healthcare, and that's kind of divided up into different ways of delivery. And as Jonathan's alluded to, some of that is with partnerships. So we are in partnership with Jonathan's trust within the London prisons. We're in partnerships with Sue, who we'll come on to later, around some of our other areas, such as the Midlands, and that's around mental health and substance misuse. So we give a really kind of mixed shared care, integrated care system into prisons across the UK. I think a bit about my background. I'm a mental health nurse. I actually trained with Vanessa, so many years ago. I qualified in '95, so slightly before you, Jonathan.
Yeah, I know, I thought that too.
Yeah, so
in the 1990s,
yeah, long time ago. And I think, I started my career in forensic mental health, actually, in various kind of, crisis and rehabilitation, and then moved into, I could see the kind of integration of patient needs. So I moved into substance misuse in the community after that, because, to try and kind of understand the system that patients were trying to navigate and all the complexity around patients. So I spent quite a few years in community drug services, working with DTTOs, Leeds Addiction Unit when it was there. And then moved into, so it's probably accidentally moved into prisons. It seemed like the natural next steps, given that we were working with a lot of vulnerable people who were on that criminal justice pathway. And then going into prisons, probably as a head of healthcare, really opened my eyes into the opportunity that prison can present for healthcare, for prisons, for patients going into prison. It's kind of uniquely placed, really, to provide a wraparound service for people, and lots of vulnerability, people that maybe won't access healthcare in the community and then come into prison. So I think that really felt worthwhile to me. So I've kind of continued within this sector, and worked in police custody services as well as part of that ongoing pathway, police custody healthcare, and continued into prisons, and now into the role that I'm currently in. And I think, like Jonathan said, the role I'm currently in is working a lot with our partners and how we can try and not just give a kind of offering of healthcare to patients, but how can we transform services so that we can really help patients get to the next stage and hopefully move on past prison to thrive and flourish once they leave. So I think that's, we're all on the same page with that. We're kind of trying to optimize opportunities for people to really flourish and, lead fulfilling lives post-prison. So that's me, really, Vanessa.
Yeah, that's
Thank
great.
you.
So some quite similar themes there as well, really. Yeah. And Sue, would you like to introduce yourself?
Thanks, Vanessa. Hello, everyone. Good evening. So I'm Sue Parkes. I'm the regional lead for Midlands Partnership Foundation Trust Inclusion, Mental Health and Substance Misuse Services. So I lead the mental health and substance misuse services for the West Midlands, which includes 10 prisons. I've equally been with the service now for probably just over 3 years. And again, as Jonathan said, I'm really privileged to be involved in this service, because for me, it's an opportunity to really give to give that support to people who really are at that point of need, and probably the most vulnerable and needy, and have the most number of complexities that we experience in healthcare. So it's a great privilege to be involved in this service. So in terms of where I've been, obviously you all talked about your starting date. So mine slightly is above yours at 1990. So that's when I qualified. So, and I've worked across the West Midlands in various roles in mental health and substance misuse services. And again, I was very lucky to work in Wolverhampton in the late 90s. And that was to develop all of the mental health and substance misuse co-occurring needs services, both for alcohol, criminal justice services, working again in police custody suites, and equally working at Leeds Addiction Unit as well, Dawn, actually. And that was with
them.
Sorry, Vanessa.
I used to be connected with them as well, work-wise. So,
yeah.
Yeah.
Oh, funny. And that was a real privilege, because that was probably one of the highlights of my career, actually working with the UK alcohol treatment trial, which was working with some wonderful colleagues across the country, Gillian Tober being one of them. So I was very lucky to be involved in that, and then moved on back to mental health, actually, to implement the National Service Framework when that first was implemented in Staffordshire. And then from that, other various jobs, particularly then going back to the substance misuse field and developing the drug intervention programme, which again had a very criminal justice theme in terms of ensuring that people were supported from custodial settings to community appointments and so forth. And then latterly, prior to coming back to this service, I was actually leading the transformation programme for Staffordshire and Stoke for mental health. So in terms of that transformation and that real understanding of where the developments are required and innovation is, it's a great that was a great experience that I can then, obviously transfer into our services, particularly in light of our recent new award for Staffordshire, and also for the Isle of Wight, in terms of ensuring that we have some parity with what a community offer looks like. So yes, I'm very, very happy to be here, and really interested in talking about the conference, intersectionality, and what mental health as best practice looks like within a custodial setting. So thank you, Vanessa.
Brilliant. Thank you all. It's great to have so much experience on the call, isn't it, Nikki, tonight? And what strikes me is everyone's connected with that same interest in kind of working with people who are vulnerable and who are at the most complex end of the system. And I guess similar to Jonathan in a way, I didn't always work in health and justice. I've always worked in the sort of acute end of mental health, and I've always been passionate about social justice and inequality. And I ended up working in health and justice through Dawn, actually, by chance, really. And what struck me as soon as I worked in the area was I should have worked in this area throughout my whole career, really, because it offered everything that I was interested in and passionate about, and that opportunity to work with people at the most vulnerable, and in a much less sort of medical model, much more psychological, holistic kind of way. So I think we've all kind of said that really in a different way tonight. And I guess it leads me on to my first thought, which is around, how do we change perception? Because I think for people who've never worked in health and justice, this is perception that it's dangerous and that, it's a violent place to work. And actually, yes, of course, there is some violence and aggression, just like there is in any other area of mental health and society generally. But that isn't what health and justice is about. And actually, most of the people we work with are really vulnerable, aren't they? So I wondered if you all had any thoughts about that.
Yeah, can I come in there? I think having come from secondary care services traditionally, and moving into specialist services, I thought our prison's going to be really dangerous and scary places. And it's still a memory for me going into a prison setting for the first time, and walking into Pentonville, and thinking, oh gosh, what am I letting myself in for? But
Yeah.
Having run the services for with college for 4 years, what I see is a far lower rate of violence and assault on our workforce than I saw in previous service areas, particularly inpatient acute. It's not comparable, the levels of violence and distress. Now, it doesn't mean it's not it doesn't bring its challenges as an environment. There are constraints on how we can work effectively, but those are things we're working with. There is a regime in a prison that we have to work with, and that brings some limitations around how we work. But I think the gratitude that we see from service users who we provide care to is really evident, and it's a very rewarding place to work. And the team spirit that we have there, especially when we're integrated well with prison colleagues, with other parts of healthcare, we're planning people's releases into the community effectively, supporting people maybe to be, referred for a hospital assessment, welcoming people back from hospital assessment into prison settings, really creating a therapeutic space for individuals who have really complicated histories. And we are talking about a population group which is quite different to a traditional secondary mental health care group, where people have their own history of multiple and complex deprivation, and yet these individuals are still coming into a prison where there's further traumatization. So I think we're uniquely placed. We have a fantastic workforce, brilliantly skilled, talented, motivated, compassionate, and our workforce really wants to transform the offer, change the culture, work with the other partners, work with the prison establishments, and we have secured full commitment to change how we work, in our prison establishments. And I think we're right on the cusp of seeing something really significant change ahead, with our new model being brought into place. I think for people who are watching, and you may have a curiosity about coming into a prison setting, come and visit, come and see our services, and maybe we can dispel some of the myths. And we'd really welcome your interest. We've got lots of fantastic new roles. Psychology posts, therapy posts, speech and language therapy post nursing roles, where we've had additional generous reinvestment, for our prisons over the coming years, and we're really keen to get people on board. So I've just turned that into a little recruitment speech. Now I'll stop there.
But it is. But I think it is a great opportunity, as you're saying, for people as well, even for people who don't necessarily want to work in health and justice, to actually come into a prison and see what it's like. Because even working in the community, you're going to be working with people who come into contact with the criminal justice system. And when I look back to when I worked in acute wards, and of course worked with the police and worked with the criminal justice system, but I'd never visited a prison. I didn't really understand that part of a person's experience. So I think I think just visiting a prison as well and understanding the prison environment is really helpful for people working in mental health as well.
Sorry, go ahead, Dawn, it's fine.
I was going to say, there is an opportunity as well. I mean, talk about what Jonathan was saying. There's an opportunity, I think, for nurses and student nurses particularly. It's a really good place to come and do a placement. And, the variety of experience that you can kind of experience through that pathway is a really enriching experience, I think, for students. So if you are kind of listening and you're curious, then a student placement is a really good place to start as well. And then I just wanted to go back, Vanessa, to what you were saying about the kind of perception of violence and risk with prisons as well. And having worked in community services where you actually do come across probably people that you haven't got previous knowledge of, as Jonathan said, sometimes the risk is higher in the areas that you wouldn't expect it to be in the community, because you do meet people that you know, you have no prior knowledge of their past experience or history, whereas in prison people come in and you do usually get some information about them and can work with them on some of their, you know, issues as they come through the reception. I think the other thing to say around that is that prisons are moving towards trauma-informed working as a whole system approach, and I think it's probably a really important fact that if you're dealing with people, you know, that are traumatized coming into prison and have levels of trauma, trying to increase trauma-informed interventions, both from healthcare staff, but also from prison staff, is actually acknowledged, and lots of prisons are now trying to move forward with that as an agenda to try and reduce risk, you know, to de-traumatize people rather than re-traumatize people when they're actually in prison. So there is a big general move towards trauma-informed care, which I think is really welcomed by healthcare services and by prison services as well, because obviously that gives people tools to work in a different way as well with some more vulnerable people.
Yeah. I think we'll come back to the trauma-informed care as well in a minute. Sue, did you want to come in at this point?
Yes, I was going to add that I think that, you know, the mystique, if you like, around working in prison is should be absolutely clear that we are working with people who would have been in the community and who are going back to communities. And we're actually, again, we're working with people who are people that are on a journey and ended up within the criminal justice sector. So when I was leading mental health services 20 years ago, when prison mental health services became a new entity, I was asking colleagues if they had an interest to come and work in a prison. And it was a challenge to actually identify people because of, you know, as I say, the mystique, etc. So I said, well, I'll go and make a start. So I went in myself and so I was working, so it's 21 years ago now, actually. So I was working in Dovegate prison, probably the first mental health nurse in the area to do that. And actually it was great. I ended up staying, actually doing a clinic an afternoon for 2 years. So, but obviously with that, you know, colleagues were encouraged to come in, shadow me, and we kind of developed that cohort of nurses who were, and other colleagues who were interested. But in terms of the violence and fear factor, I think, you know, talking to colleagues who worked in the system for a long time, that they would absolutely agree that isn't a worry, that isn't a fear. And as I said earlier, it's a great opportunity to really make a difference to people who probably, you know, if there is that violence, etc., or level of aggression, it's often down to frustration. And we are there as a collective to be responsive and supportive and compassionate to people. So we don't see that. We don't see it. So that is a definite myth buster that people need to understand. And it's a fascinating, privileged, wonderful place to be, to as I say, make that difference to people's lives. And I'd echo Dawn's point about student nurses. We've got a good connection to local universities for nurse training. And we have a great cohort of student nurses that want to join us. And we also have newly qualified staff nurse places as well. We've just recently appointed a colleague who's really enjoying working with us, and I know he's really happy to spread the word to other nurses to join us too. And that obviously goes across the other professions that contribute to the multidisciplinary team. But in terms of the nursing cohort, it's something that we're really working hard with colleagues to, as I say, myth bust and understand that it isn't something to be fearful of, but something to be really embracing and be a really good opportunity for development themselves, actually. And I guess we'll talk a little bit more about what those opportunities look like a bit later.
Yeah, definitely. And I do agree. And I know nationally there's work going on, isn't there, around developing nursing placements in particular in prisons and helping people to understand, you know, what it's like to work in a prison and to encourage placements. But I agree.
I've got some questions actually from students, if you want.
Brilliant. Yeah.
So one of the questions is, actually, I'm a student nurse and want to do a placement. How do I go about doing that? Someone said, you're talking about misconceptions about working in prison. What are the biggest misconceptions that you've come across? And another student has asked what's happening around suicide and self-injury, because it's worrying. And then somebody else has asked about what happens around dementia in prison. So how do you get a placement? Perhaps is a good place to start.
Yeah, who would like to answer? Who'd like to start?
Well, we've got links, as I said just earlier, to the universities and in terms of clinical placement facilitation. So we have a lot of contact. We provide information sessions. We've got a lead nurse, Hannah Davis, who works as part of her role to link with those universities and link with the clinical facilitators. We've obviously got a range of mentors across a number of our sites. So that's happening. So if the nurse inquiring is in Staffordshire or around the Staffordshire area and wants to talk to any of us, then please leave a contact link and I'll get back to you. So yes, we absolutely do encourage student nurses and have some great mentors.
I think the other, just to add to that as well, I think if people are in different areas around the country, usually if you speak to your clinical placement coordinator, they will usually have a link to either the organisation that kind of delivers into your local prison, or if you go on the prison website, you would be able to find out which healthcare organisation delivers into that prison. So your clinical coordinator would be able to support you with that placement in order to try and, organise it. I would say you do probably need to plan it a little bit in advance, just because you do have to do some vetting, around checks to get in. So usually they can take a few weeks as well. So it's just worth having a chat to your tutors around, trying to organise placements and just planning a little bit in advance.
Yeah, definitely. And I think as well to add that we do link with universities. So I do sometimes get requests from universities, things like students who are doing a reflective practice piece and helping universities understand the context, or people who are doing research. We have a research committee at Practice Plus Group, and certainly, we often have people contacting us who are wanting to work with us in a research capacity as well, which obviously we encourage. So I think, as has been said, really, you can get in touch with any of us on the call tonight if you're interested in a placement in prisons. We're happy to help and direct you depending on where you're based as well.
I think the other things that are coming around you guys have really raised the issue of vulnerability and that kind of trickiness. So how do you cope with someone who is both in prison and also vulnerable? So the questions were particularly around suicide, self-injury and managing dementia, which I'd imagine are complicated. So if anyone wants to jump on that.
I think that's a very broad question, because there are all sorts of vulnerabilities that we encounter in prison settings. I think if you think about suicidality in prisons, we are very careful with our processes in terms of reviewing previous incidents and history of occurrences of these tragic events where people lose members of their families. We have a very thorough reviewing process, and the purpose is of this reviewing process, which which are conducted in partnership with commissioners, is really to establish what learning we can gather from historical events. What this has led to in London with PPG and partners is a redesign of our service, and this means that we're targeting times in the care pathway where people may be at their most vulnerable, and adjusting the care that's available at those times. For example, if we look back at previous incidents over the last 3 years in our London prisons, we see significant vulnerability in the first few weeks of being in custody, especially if you're new in custody. And if you're a certain age and if you've got a surprise long sentence, there are multiple risk factors that will indicate that somebody might be representing a greater risk to themselves. So we've in our service redesign, we've put far more resources at the front door, so that we will have fantastic ability to collaborate and coordinate the sharing of information across previous care providers into the prison setting, and really create safe care plans for individuals. The idea being that hopefully we'll really prevent more occurrences in the future by having excellent sharing of information including previous treatment history, including the person's family context, their own history of risk. So a really thorough risk assessment with information shared, not only within the health sector within the prison, because then you've got physical health, mental health, substance misuse, but also with offender management and also prison colleagues as well. And in that case, you should have the creation of a rounded formulation of a case. I think that's one thing that we're doing, service redesign, learning from incidents individually and also systemically, and really seeing the person as a whole. I mean, that's our assessment methodology is critical in this. What are the circumstances this person's in beyond having a formal diagnosis? What is their life like at this point in time? And it's about retaining compassion, retaining a whole view of the service user. So yeah, we're doing a lot around reducing the risk of deaths in custody. I think we're making good headway with the changes that we're making to be safer. It's a real tragedy. Every case where we have a loss is a tragedy.
Yeah, I think as well, on that point, it's links to an earlier point I was making about prison being a sort of less diagnostic from a mental health point of view, because for me, there's something about somebody in the community who's feeling low in mood would have lots of protective factors around them, like friends, family, going to the pub, exercise. People come into prison and they don't have those factors. So it's understanding that the context of the risk relating to the environment that they find themselves in, and looking at how we can support a person. And for me, that's how the whole system can support the person. So from healthcare staff, including, primary care staff, through to prison, and taking that sort of whole systems approach to suicide prevention so that everybody is skilled in asking those questions. And the other thing for me is around clinical curiosity, about asking those questions about a person's background and current position, and like really understanding how that impacts on the person. And we're doing Work in Practice Plus, which I'm leading on around suicide prevention, and looking at the training in particular, looking at it almost like Maslow's hierarchy of needs, like what's the sort of basic level training that everybody needs to have around suicide prevention. So we're piloting training where we're involving both the prison and the healthcare staff together so they can work collaboratively around suicide prevention. And then, there's the more sort of specialist training that the mental health practitioners do, and also looking at our peer support systems as well, and how we can help build awareness amongst people in prison so that if they're sharing a cell with somebody, they can detect if somebody's distressed and have that conversation, as well as having the listening scheme in prison as well. Which is linked to the Samaritans. So I think there's so much that we're doing, and also for me linking in with the wider system, because a lot of the suicide prevention work that's going on in the wider system traditionally hasn't involved prisons. It's like prisons are a closed culture that are separate from the rest of the healthcare system, and that's changing. And it's been really good to work with some of our integrated care systems as well around the country, and link into the work they're doing as well around suicide prevention.
Another load of questions come in, and we haven't finished the last lot. We have to speed you guys up, man.
We've got so much to say, all of us, haven't we? Go on, Nikki.
One of the other questions we've got is it true that if you get dementia in prison, you get to go home? Is that true? I love these questions. I love the questions.
It's an interesting question.
It really is.
Go on, Jonathan, did you want to come in?
I was just wondering who was asking that.
Yeah.
Along with Mushtag, hello, another question from Mushtag. How are the shift patterns in mental health and justice? So people are coming at this very practically.
I mean, dementia in prisons is, I'm sure that Jonathan and Susan want to come in as well. And I think, as with the rest of society, obviously it's emerging as an increasing issue, in our older population. So as other healthcare sectors, everyone's kind of working out how we can best adapt, to look after people properly in prison. I suppose my blanket response to the do you get to go home if you've got dementia, then is probably no. But we've got, people have a range of needs in prison, and actually sometimes the routine of prison kind of perversely can support people with things like dementia, because the routines are very precise. It's the same process every day. So in some respects, people with dementia can fare reasonably well, but there's a lot of work to do with it, and I think it is quite patchy across the country. Some places have got dementia friends, and there's a lot of work around older people as well. So there's older people cafes, and things being set up to support older people in prison. The population is aging in prison, so there's a lot of work underway. It's not consistent, I would say, across the country at present. So but Jonathan and Susan want to add to that.
Yeah, I think you're right, Dawn, and it's an area that obviously can also affect younger people in terms of alcohol-related dementia as well, in terms of costs. So it's an area that obviously we are exploring at the moment in terms of our contract mobilisation plan at the moment, in terms of that integrated pathway. But I think not wanting to take us back, but in terms of the vulnerability agenda, which obviously relates to the people who may be suicidal as well as have dementia and other concerns, that there's a lot of work we're doing at the moment around that connectivity to community services, either as an in-reach arrangement, so for services to come in and work with us to perhaps deliver kind of talking lounges or community lounges, which obviously can support people either who have whatever diagnostic condition, but also to ensure that people are connecting, so that when people are behind a cell door, that they're not isolated. They know that they've got a community to link with, and they've got people to talk to, especially men, as we know, who may not be forthcoming in terms of talking about their feelings and what's going on for them. So that's something we're really working hard on at the moment. And again, that links to some of the community transformation work as well, and the community-led support programs, and how we can replicate that within a prison custodial setting, because it's where it's most needed. So we need to make sure that those resources, as much as we can, are available to people in that setting.
It kind of takes us back round to some of the things that are coming in. So somebody, I think their name's the wrong way around, but Rodriguez Abrotesi has said, most people in prison are highly vulnerable to multiple factors. Part of our role is to assess and formulate needs and risks in collaboration with patients and different agencies to identify areas of intervention. Risk assessment is dynamic and requires regular review. Using a trauma-informed approach helps us keep the person at the centre and keep them in context. And Michael Haslam has then also commented, trauma-informed and relational working is essential. Some amazing work going on, particularly around OPD pathway, promoting relational working and interpersonal effectiveness within CGS. If anyone wants to talk about that, maybe that would be helpful.
Yeah.
Well, we actually, our conference, we have our OPD, our pathways service presenting at the conference that's coming up. On how to engage young people from a diverse background in healthcare provision. So it is they do a particularly great piece of work, the pathway services and OPD across prisons and in community. And we're lucky we provide in collaboration with another trust into the Oxley's partnership across London for OPD. So we're really excited and very proud of the services. I think
briefly say what OPD is, because perhaps people
it's a focused commissioned piece of work targeting people who have significant psychological difficulties. I'll talk specifically about the Aylesbury service because that's one I'm really familiar with. So this is a pathway service in Aylesbury, and they have a targeted audience of service users who have particularly complex needs, particularly high risk, both potentially to themselves or to other people. And they have a fantastic engagement approach, which is much more sort of social engagement. It's an integrated service with the prison. So prison actually have dedicated staff working alongside them in a dedicated space. It's not residential within the prison. It's a space people go to, and then they engage socially initially. Obviously, risk assessed, because you've got to be quite careful about different wings mixing and so on. And then that leads people to create a trusted relationship, and that leads to them walking through the door for more therapeutic interventions and clinical care. So the community arm is a bit different, which is working with people who haven't still in the criminal justice pathways. It's working hosted by probation, in partnership with probation, again offering therapeutic input and support. And they're doing some great innovative stuff across London. And yeah, I think I'm really pleased that we've got a slot in the conference for our clinical lead to present on the model out in Aylesbury. So I think there's a fair bit to learn there, both from a health perspective, mental health perspective, but also from a prison perspective, particularly about partnership and how to create trusted working relationships in a custodial setting.
Yeah, sounds great. And shall I just take this point a little bit about the conference for people who are listening, so they know how they can get involved? So, as Jonathan's mentioned, we're having a health and justice conference on February the 20th in London, which is on the theme of intersectionality, which we felt was really important to talk about, just to emphasise all the different parts of a person's identity, and then how we set that within a trauma-informed context for people coming into prison. So the focus of the day is lots of speakers and workshops around different themes of intersectionality, from gender, culture, neurodiversity, and then lots of examples of our good practice workshops across all our organisations who are involved. So I know I've had quite a lot of interest already on social media, and for people who can't attend because it's limited capacity, but we're hoping to do a much bigger event next year, you can still join in by following the MH Injustice hashtag, which we're monitoring and feeding in to the conference on the day with any questions. And we will be live tweeting a lot of the discussions and conversations. And we've got an artist who's going to be doing some visuals for us as well. So there are lots of opportunities, and there'll be also lots of MHTV interviews after the event as well, with some of our speakers who are interested in being interviewed on here. So watch this space on here as well, if anyone wants to add anything, but I think that probably covers it. Yeah, great. Nikki,
it's a short time, so
yeah, we are actually. We're coming to the end already, aren't we? So just, I guess, so that we kind of cover things that we wanted to cover, I think maybe if I just go around the screen and just, if there's anything else that our guests want to pick up that we haven't covered, should we do that now? Sue, I'll start with you at this end.
Okay, thank you. I think I just wanted to reiterate, the comments that have come through around trauma, that certainly for myself and colleagues, that to address the trauma impact for people who are in receipt of our services is probably one of our number one, focus, really. We've just been very fortunate to recruit a psychology colleague who's going to be leading our psychology agenda. And that will be involving, again, a number of recruitment opportunities for new psychologists to join us. But for me, it's how we really connect with that, and ensuring that we protect people and keep people safe, and take the opportunity whilst in custody to really address that trauma, because often it's transgenerational. And again, that's one of our topics for the presentation at the conference, is transgenerational trauma for young people, which would be a great workshop. So yes, I think for me it's just really expressing the absolute importance of everything that we do around mental health, from what we often class as primary mental health need to acute care. And we're very fortunate to have a range of great colleagues that are very passionate and compassionate in terms of what we do and want to make that real difference. So it'd be great to have that opportunity to come together at the conference and share thoughts, ideas and presentations. So yeah, thanks, Vanessa.
Definitely. Thank you. That's good. Dawn, over to you.
Yeah, thanks, Vanessa. Thank you, everyone. Well, I think from my perspective, and it's similar to Sue, is to emphasise the kind of whole system integrated approach, and that's hopefully what we'll demonstrate at the conference, which is if you kind of wrap the services around patients, that's definitely the way forward, and that's how patients are going to get the best from us as a whole system. So I'm hoping that the conference is going to kind of demonstrate that and offer some real opportunities for learning and sharing.
Yeah.
Thanks, Vanessa.
Thank you. Jonathan?
Yeah, I second everything Dawn and Susan have said. I think the conference is going to be fantastic. Looking forward to future years of conferences as well, as we come together, as a community of providers to really share our experiences and show off our innovations. Let's continue to create an optimistic and hopeful tone for the services that happen in prisons. I think it's great that we have this theme of trauma-informed care, and I think it focuses on the two most important factors, around mental health care in prisons, which is one, keeping a focus on the service user as a whole, and two, looking after the well-being of our colleagues and employees who work on the front line. If you're curious, come and see us, come and visit us, reach out. We've got lots of exciting new posts, and please do get in touch.
Yeah, that's great. Thank you. And Nikki, anything to add? Any final questions or anything?
No, I'm busy tweeting away. But it's been really interesting. Thank you. I've enjoyed it.
Yeah, no, I'll just end then really by saying it's been brilliant discussion tonight. I think we could have talked for much longer, and I think in the weeks ahead, obviously we're going to have more health and justice themed conversations, which is really exciting, I think, to get it on the agenda publicly. And I think, as we've kind of demonstrated tonight, it's a really exciting place to work, and there's loads of opportunities, not only for our students coming in at the beginning of the careers, but also development opportunities for people who are, further on in the career and want to specialise in health and justice. So, join us in the weeks ahead. Next week, we've got neurodiversity in health and justice. So that's going to be a great topic. And as with all our MHTVs, everyone's welcome to join the conversation. We've got the conference, as I say, on February the 20th, which is MH in Justice hashtag for you to follow along with that. And I think that's it. I'll just say good night and thank you, everyone. And thanks for listening.
Thank you.
Thanks. Bye.
Bye.